Recording started.
Alright, good morning, guys. As last year, when we updated our CPR and recertified, every 5 years American Heart updates their standards. Obviously this year there was quite a few big changes that happened. What we're going to do today is this EMT training that we're doing is going to be in 2 parts. Today is going to be lecture. I'm going to go over the guidelines, what they changed from 05 to now, and so we have a few videos. And then what we're going to do is next month, myself and Kevin Sousa, who are the BLS instructors for the department, have to go to American Heart website, get certified, and get okay through our training center. And once we are able to do that, then we can certify you up on the new updates. So what today is basically a lecture. And then once that's all they're done with next month, once with the guidelines and everything comes out, I will be coming out one morning or whatever else, and we'll be doing the demonstrations, the skills, and there will be a new test out. Okay, so let's go ahead and get started on that. Where do the guidelines come from? Obviously, it's a multi-year process involving the experts from around the world. The results are in the following publications: the 2010 Science and Treatment Recommendations, and in the 2010 Training Guidelines, American Heart Guidelines for CPR and ECC, and the 2010 American Heart Guidelines for First Aid. Today, all we're going to be going over is CPR. The first aid is, a lot of it is for the lay person, but we will be touching on that when I come out as well. So, and then for any of us that are paramedics or you guys that just have gone through school, there are ACLS updates as well. The 2010 guidelines, you can go on the web and find out. You can download them, you can view them, whatever you want, but all you have to do is go to this website and go through them completely. They updated them and adopted them in October 18th of 2010, and because there were so many different changes and because of the way they do things, it usually takes months for them to get out, and in fact they come out in waves. They haven't, all of the updates that came out aren't even all out yet. They will continue to come out throughout the year. Okay, so the new updates that have just come out are, a lot of it is just strictly for CPR and some of first aid, and then ACLS and different things like that will come out later on. CPR and AED. Obviously, what they have done is they've emphasized on high quality CPR. The 2005 guidelines, basically the blood flow is optimized by using the recommended chest compression force, duration, and maintaining chest compression rate of approximately, okay, I want you guys to remember, approximately 100 compressions per minute. These guidelines recommend that all rescuers minimize interruptions of chest compressions. CPR instructors should emphasize the importance of allowing complete chest recoil between compressions. Obviously, we try to do that anytime we go up there, but the key right here is the approximate 100 compressions per minute. Okay, now the new guidelines that come out, hold on. Go, okay, there. The newer guidelines that came out emphasizes some other different things, and they've actually changed them up a little bit. So what we're going to do is I'm going to play this video. It's only like a 2-minute or 6-minute video, and then we will go into the 2010 guidelines. Now, this video right here, guys, when you can start it whenever you want, and then when you're done, if you'll just give me a thumbs up or something and let me know that it's done, I would appreciate it.
The American Heart Association is the nation's leader in life-saving CPR training. In fact, we write the CPR guidelines for everyone: the public, doctors, nurses, and paramedics. This year, we've made a few changes so that it's much easier for anyone to save a life using CPR. Let's take a quick review of the new CPR process and when to use it. When someone's heart stops beating, it's called cardiac arrest. CPR is needed right away when this happens. Cardiac arrest victims will die if they don't get help fast. When cardiac arrest strikes, the victim typically collapses stops breathing, or stops breathing normally and can't respond. If the victim does not respond, and the victim is not breathing or not breathing normally, the officer is going to call 911 and have them get an AED. An AED is a portable electronic device that helps the heart return to its normal rhythm. If you're alone, call 911 and get the AED yourself, and follow the AED's voice prompt. If no AED is available, immediately start CPR, beginning with compressions. Beginning with CPR is not hard. Anyone can do it. And now the American Heart Association is making CPR easier than ever. We used to tell people that the proper steps for CPR are airway, breathing, compression, or ABC. But we've changed that order, and the compressions come first. It's now compression, airway, breathing, or CAB. This new order makes it easier because anybody can start out with compressions, even without CPR training. Just push hard and fast from the center of the chest. If you haven't been trained, keep pushing until help arrives. When you give compression, make sure you push the chest down at least 2 inches and allow a little time for the chest to come back up. Push as hard and fast as you can. The perfect rate for compression is at least 100 per minute. That's the same speed as the beat of the song Staying Alive. So try to keep that tune in your head if it helps. If you've been trained in CPR, push on the chest 30 times.
Okay, most everybody reading.
Well, let's check on them on the island. Can you guys? Was there a lot of there was a lot of feedback in the initial part of it because we didn't shut our mic off here. Let me see. Please turn off your mic. Okay, sorry about that. Hard to hear. All right, go ahead, John.
Okay.
I tell you what, everybody give us a...
Most everybody's got to give me a check mark.
Yeah, give a check mark. Okay, good.
Okay, good. Thanks, guys. All right. This whole new thing that we're doing right here, guys, this is kind of new. This is our second day doing it, so we're kind of still working out the bugs, so be patient with us. What you guys saw in this whole thing is it used to obviously be ABC. Now they have changed the CAB or CAB. The reason that they have changed it to compressions first is that they feel like that the high quality compressions that you can give someone will benefit the person better than just taking that time away to stop, looking, are they breathing, let's open the airway, look, listen, and feel. Obviously we used to do it for up to 10 seconds. No, they're not breathing, let's check the pulse, or give 2 breaths, and check the pulse. You're wasting almost, they figure, anywhere from 20 to 30 seconds to sometimes longer. They feel like that as soon as you get up there, what they're seeing now there is you look at the patient, see whether or not they're breathing or not. If they do not look like they are breathing at all, you don't even open up the airway. You immediately check the pulse, no longer than 10 seconds, no pulse, immediately start CPR, okay? And what they have changed here is, like I said before, the O5 is approximately 100 compressions per minute. Now what they're anticipating, or what they would like for us to at least 100, okay? And with a depth of at least 2 inches on adults and older children, and to allow the chest obviously to completely recoil. All right. Like I said, the reason they have found that the quicker we get blood flowing to the brains and the vital organs, the better off these patients are going to be. But they have also, and I'm not sure whether or not they're going to touch on it in here, is what we used to do, if we do not find them, if they don't go into cardiac arrest right when we are there, okay, we did CPR for 2 minutes and then apply the AED. Now what they emphasize on is that as soon as you come in, this patient is unresponsive, check the pulse, and you start CPR, the next person, whoever your crew, immediately apply the AED, turn it on, and see what rhythm you got. If it's a shockable rhythm, you shock it immediately. You don't wait your 2 minutes anymore. Okay? So we may touch on that a little bit more. Exactly, it does. And this is the study that they do. This is why they constantly update this thing. Okay? So the highlights, obviously, from 2005 is this push fast, push hard, allow for full recoil, and minimize interruptions. Obviously, we try to do that. Remember what we said last year and everything. less than 30 seconds off that chest. All right, 10, 15. As soon as your 2 minutes is up, we rotate. Next person gets on there and starts the CPR. Okay. Every 2 minutes you switch. Okay. That way it reduces fatigue on any individual. Okay. That day when Chief Souders passed away, it was myself, Chief Losig, Captain Jasinski, and Rodney, and every 2 minutes we were trying to rotate. And obviously there was times where we would do it a little bit more, but it was just, it was almost 40 minutes that we were doing it. And it took a toll on all of us. So, excuse me. Obviously, the rationale for the change was high-quality chest compressions with CPR continues the critical focal point, and well-performed compressions increase the likelihood of survival. Okay? Hand position has also changed. Okay? 2005, you put the lower half of the victim's sternum in the center of the chest between the nipples. Okay? The rescuer should place the heel of one hand on the sternum in the center, and the chest between the nipples, and then place the heel of the second hand on top so the first hands overlap parallel. Alright, so those are 2005. 2010, now what they are saying is the hand of one over the center of the victims, which is the lower half of the sternum, not all the way down on the xiphoid process, okay, but not so far up, okay. A lot of people, especially women or whatever else, it's hard to determine where the nipple line is or the center. So now what they're saying is when you do up there, the way they used to teach years ago was you'd find the bottom part of the ribs come right up, and right above the xiphoid process is right where you put it, 2 fingers, okay? Then they moved it up farther, okay? Well, now what they're saying is now let's move it back down on the lower part of the sternum, not over the xiphoid process, okay? Remember, you don't want to go too far down in here. It's just right up above. It's almost like once as your ribs come up right here, about 2 fingers. And then as you can see, bam, you're right there. Where it used to be years ago, okay? And that's what they're saying. That way, they're finding that right there gives better compressions.
So 2 fingers above the xiphoid.
2 fingers above the xiphoid process. You find the bottom parts of the ribs if you can. Just run your fingers up, 2 fingers, and put the heel with your hand right there, and obviously your other hand right above it. Okay? Highlights the center, hands in the center of chest, lower half of the breastbone, second hand on top, not on the lowest part of the breastbone. Okay, remember that xiphoid process you can break off, and we don't want to do that. Does anybody have any questions so far? Everybody good?
Were we all hyperventilating, or did you do it proper?
No, we were in the beginning, of course, because of who it was, we found ourselves kind of hyperventilating and not doing the compressions right. But once everybody kind of calmed down and got everything going, we started the proper compression rate, switching every 2 minutes and not hyperventilating the guy. We never got one. We finally, because we couldn't tube him at the house. They tried 2 times to intubate the guy, and because he's very interior, they couldn't get the tube in. So, well, that's in route. They finally put a combi tube in, and we finally got there. And then once we got the combi tube in, we got his saturation and his CO2 and everything else, his capnography, everything else started working out. But by that time, we'd already been on scene for 30 minutes. So, in the beginning, obviously, we were probably hyperventilating him a little bit too quickly. We had Chief Losik and Captain Jasinski were up at the head mostly, while Rodney and I was setting up the drills and getting all of that set up. So, the rationale for the change of the hand placement is use of the nipple line as a landmark for hand placement was found to be unreliable. Okay, they just found out that because of, like I said before, people's nipple lines change and the center of the chest change, women, so they weren't getting the proper placement. Some people were way up high, some people were down too low, so they figured let's just simplify it the way it used to be years ago, bring it right back towards the bottom, and they did. Compression rate. Obviously, this hasn't really changed that much. 2005 is there are some insufficient evidence for human studies to identify a single optimal chest compression rate, and animal and human studies support chest compression rate of greater than 80 compressions per minute to achieve optimum forward blood flow during CPR. We recommend a compression rate of about 100 compressions per minute. Again, they're saying about, okay, and this was 05. Obviously what they have changed is now they want at least 100. If you go over 100, that's fine, but they want at least 100. So when you're doing compression, you keep that beat up. If you go above 100 compressions per minute, fine.
The faster the better?
Not really the faster the better. They're thinking 30 compressions in 18 to 20 seconds. Okay, that will get it. If you guys remember last year when I trained you, when we were going through it, we were doing 30 compressions in about 15 to 16 seconds, right in that area. That's what we were doing. Okay, and that was a good steady pace. Now what they found is that, okay, that's not really getting enough, all right? We're not still getting up to almost 100. So now let's go at least 100, and that's why the Staying Alive song. Okay, I've programmed all the new AEDs now, and now that plays that song.
You can actually play this.
Yeah. No, they you know what that's why that song is upbeat, and that's what they got. Let's keep that song in there, and you keep that rate up, and that's why now they think anywhere between 18 to 20 seconds, you can get your 30 plus compressions. Okay. So obviously, the reason for laypersons and healthcare providers to compress the adult chest at a rate of 100 compressions per minute with a depth of 2 inches. That hasn't changed. It's still 2 inches. Okay. What has changed a little bit is the depth in infants and children, and we will touch on that here in a few. Again, these are just the highlights. 100 times per minute. It's okay. It's okay to be a little faster, okay, Jay? Right there, what they're saying. It's okay to be a little faster, And then applies to obviously applies to us, and then the lay people. The rationale for change has been found higher survival rates are associated with an increase in number of compressions provided per minute. Okay? So that is what they found. Less isn't always better. More is.
When there's too much.
What's that?
Yeah,
there can be too much. Obviously if you're sitting there pounding on your chest so fast that you can't even keep track. But when is that going to most likely happen? And would it happen in an infant, child, or an adult? Infant or a child. Most times, if we get a call for a child or an infant or whatever else like that, that's when our adrenaline's going to be up, and we're going to probably go a little bit faster than what we need to, because we're like, we got to do something. Okay, and remember what I've said in the past, and what we all know. Okay, if an infant or a young child, goes into cardiac arrest, there's usually most of the time the two reasons, unless they have a medical problem, is trauma or respiratory. Okay, so try to remember that. Okay, the compression rate 2005, push fast, and the push at a rate of approximately 100 per minute. This is for a child and an infant. Again, the only thing that changed was right here where it said that at least 100 compressions per minute. Again, a child, if you can use infants, we use 2 fingers up to 1 year of age. After 1 year of age, you use 1 hand. Okay? Obviously, if it's a bigger child or whatever else, you can use 2. But just like the picture shows right here, 1 hand on the chest, the other one on the forehead, keeping that airway open. Okay? Again, same thing with infants though, and children. We do not stop. Check an airway, open it, look, listen, and feel. You sit there, you take a quick look. Are they breathing? No. Check a pulse? No. Immediately start CPR. Okay?
Yeah.
The depth we're going to go over right here in just a second. Okay? Highlights again. A lot of this is repetitive, guys, and I apologize for this, but this is what American Heart wants us to do. They want to cut it and drink, because we have been programmed for the last 5 years plus that this is the way it is. If we can continue just to reiterate why they're doing this, we can get it in our heads going, okay, this is what, right? Boom. Go out on the call, okay, wait a minute, I got to do it this way, So, they tend to slow compression, at least 100. It's okay to be faster, and then obviously it goes to both. The rationale for a change, again, same thing. Compression depth, 2005, is 1.5 to 2 inches, approximately 4 to 5 centimeters, and then allow for chest to return to its normal position. Hold on, John. It said as hard as you can. Didn't it? I don't know. Let's go back and check where it said. It just says as fast. Okay? You got it now, buddy? Never mind. Oh, and the video. Okay. It just says it's as fast as it can be a little bit faster. Okay? Now, the compression rate for children and infants used to be 1.5 to 2 inches and allow for the chest to completely return to normal. Okay. 2010, it is reasonable for a layperson with tuberous to compress an adult's chest at least 100 compressions per minute with a compression rate of 2 inches. We've already touched on that one. Where did the other one go? Researchers indicate attempts to CPR providers to not press deep enough, even with the emphasis on pushing hard. Okay, we found that out too with Chief Sowers. Any of you that you know Chief Sowers, he was a big guy, but he was also he was built. Okay, I found myself, obviously, anytime that we do CPR, you can look at the monitor like I can see your waveform. Okay, there was times when we were doing it, that thing wasn't moving. Okay, so you got to watch when you're sitting there moving. Make sure you move that chest. Okay, 2 inches is a lot. Okay, when you think about on something. Now, obviously, frail older women or older men or whatever else, it's not going to be, you'll be able to. But any of these bigger guys or whatever else, it's going to take a little bit to move those chests. Did I back up? I must have backed up too far. Okay, push hard. Push with significant force to depress the chest approximately 1/3 to 1/2 the anterior posterior diameter of the chest. Okay, that was the old guidelines. The new guidelines, 2010, on children or child and infant, is chest compressions of appropriate rate and depth, which again is 30 to 2. None of that has changed. Push fast. Push at a rate of at least 100. Push hard. Push with enough force to depress at least 1/3 the diameter of the chest, approximately 1.5 in infants and children. That right there is the difference. Okay, it's right there. It's right there in bold letters. At least 1/3 the anterior posterior diameter of the chest, or approximately 1/2 in infants and 2 inches in children. Okay, so children. The ages of children can be anywhere from, I would say, 5 and up. Okay? Infants obviously are from 0 to 1. And again, right here, 1/3 of the anterior posterior diameter and 1/2 in infants and 2 inches in children. Okay? So once they get to about 8, consider them, old enough to go in about 2 inches. There's a lot of 8-year-olds there pretty big. But again, use your judgment. I mean, if it's a smaller kid or whatever else, like, I'm not sure how big Colin is. I haven't seen him in a little while. Austin, for instance, he's still little, but he's bigger. Okay? So, obviously, him probably wouldn't push down 2 inches on. Okay? But just use your judgment. Okay? Yeah, or petite girls, absolutely. All right, at least 1/3 of the anterior posterior, again, 2 inches for children, about 1.5 for infants. It's okay to compress a little bit deeper, and applies to both lay and healthcare providers. Again, the rationale for it is because for our providers to not compress deep enough, and even with the emphasis on pushing hard. Okay, so again, hard, you can. Not to, you can go down as deep as you need to, and when, push as hard as you have to make sure that you get that down, to get that chest to recoil back, or push down and then recoil back up. Remember though, we don't want to bounce our hands off, okay? But we do want that chest to completely recoil back up. Breathing assessments. While maintaining an open airway, look, listen, and feel for breathing. We don't do that anymore, okay? Activate the emergency response system. All rescuers should immediately begin CPR with adult victims who are unresponsive with no breathing or no normal breathing. only gasping. It was, Nate made a comment yesterday, well, what if they're sitting in the chair, whatever else, and they're like this, and you don't open the airway? Well, if they're unresponsive, obviously you're going to open up the airway. If they start breathing, then, you go from there. But if they're in a chair and you open it, you pull them back and they're not breathing, fill them down on the ground, check the pulse. It's no longer than 10 seconds, no pulse, start CPR. Okay? Obviously, we are going to be the emergency response system, so we're going to be called. The highlights: no more look, listen, and feel. They felt like that was just taking too long. Okay, just a quick look for no breathing or no normal breathing. Okay, agonal breaths remain a concern. Okay, it was said that any time that you go on a call, obviously when somebody does, they do start that agonal breathing. Okay, so you might want to sit there and take a look. If they're only agonal breathing, a lot of times their heart's already stopped in the air. So that's just the last part of it. And then it applies to both the lay and the healthcare providers. The rationale: central applying the breathing assessment is intended to help lay persons respond more quickly with chest compressions and CPR. That's why they're going back to the compressions. They feel like that we're wasting too much time and look, listen, and feeling, giving 2 breaths. Instead, let's go immediately into CPR. There's a likelihood of agonal or irregular gasping breaths to occur early in cardiac arrest and confuse rescuers. Okay, you get on scene and somebody's agonal breathing or gasping or whatever else, they're like, oh, hold on, what's going on? Now they're going, this person could be in VFib with VTAC, or we could immediately shock them, maybe get them back quicker. Okay. CPR sequence for lay personnel. Again, 2005. Again, CPR, open the airway, give 2 breaths, follow chest compressions. Sorry, guys. Hang on. Sorry if I'm talking a lot. Yeah, if you wouldn't mind, sure, ladies. That way, if it does go off again. 2 breaths, followed by 30 compressions, repeat cycles of 30 to 2. Okay? New 2010 guidelines for unresponsive persons: activate EMS, assess breathing. The person is not breathing or not breathing normally, begin CPR. 30 compressions followed by opening airway, give 2 breaths, and repeat cycles of 32. You still do your 5 cycles of 30 to 2, but if you have an AED that's close by or somebody can go and get it, we don't wait our 2 minutes anymore, okay, to do our 2 minutes of CPR and then apply the AED, okay? You have an AED or whatever else and you have one nearby, you start your 30 to 2, have in your mind, okay, I need to do, 5 cycles of 30 to 2. If an AED shows up, hook it up, let's get it on and see what it says. And then bam, if it shows a shockable rhythm, immediately shock. Okay? Goes for us as well. Highlights. Okay, we all know this, we're going to be the ones coming, so. Science indicates the importance of not delaying chest compressions to perform rescue breaths. Early chest compressions can immediately circulate oxygen that is still in the bloodstream. Okay? Obviously, we cannot circulate the blood as well as the heart can, but we can do it enough to where hopefully we can either get something going or save a life. Who knows? But at least that way we can get something going to where we can get the blood going from at least the chest to the brain and the vital organs up top, and we can go from there. Healthcare providers: unresponsive person is not breathing or not breathing normally. Again, CPR by opening the airway, give 2 rescue breaths. Obviously, look, listen, and feel. Not breathing, give 2 rescue breaths, 30 compressions, and repeat cycle. Hey, look, 2010. Unresponsive, not breathing normally, has no obvious pulse, activate EMS. We are, again, CPR. All you're going to do is you're going to get there and you're going to check the pulse, whether it's carotid or whether it's femoral, however you want to do it real quick. Most of the time people grab a hold of the carotid, grab it, no pulse, again, CPR. Whoever's with you, have them grab the AED, start putting that AED on immediately. Okay, normally there's 3 of us on a truck, so one can be doing CPR, one can be bagging, grabbing out the bag, and the other one can apply the pads and the AED. Okay, so, and then that way once you get going from there, see what the rhythm is, shockable rhythm, it's going to tell you. Highlights. I hate keeping up with this, guys. I know it's all of your programs are off. Rationale for a change. Science indicates the importance of not delaying chest compressions to perform rescue tests. Early chest compressions can immediately circulate the oxygen that is still in the bloodstream. The use of an AED on an infant. This is another thing that has changed. There is insufficient data that makes a recommendation for or against the use of an AED in infants 1 year of age. Okay? Remember, over less than one or over that, we kind of shied away from it because we weren't exactly sure. What they have found is that most AEDs have a significant and recognizing pediatric shockable rhythms, and some are equipped with decrease the joules, energy to make, I can't say that word. Anybody else? Jay, you know that word? Or amplitude? I got nothing. Anyway, the delivery energy to make us suitable for an infant and child less than 8 years of age per infant. An AED equipped with pediatric key. There you go. What's that word, Calvin? What's that word?
Accentuator.
Accentuator?
Yeah.
No.
Attenuator.
Attenuator. There you go. Just,
you play the second computer yet?
no.
When you do, make sure you turn off the sound on that computer. Okay. Because they'll get the echo feedback.
All right.
From the screen.
Okay.
Yeah, probably outside.
Okay. Obviously, ours has a pediatric key. Okay. So now what they're saying is because these AEDs, the AEDs that we have and they're continuing to come out, they can recognize it. Okay, and what they'll do is they'll lower the joules to the point to where it needs to. So that's why our AEDs now less than 8 and even infants. Was it Jimmy?
This one? No, that's ours. Good.
So anyway, we can use ours now for younger children and infants if it's an infant. Place it on there, see what happens. You know, if it's a shockable rhythm, obviously it's going to shock. If it's not, we're going to continue to do CPR. Okay. So that's another new change. Highlights: successful defibrillating of infants. The key obviously reduces the shock. And it's okay to use AED set for adults. I wouldn't go that far, but we won't have to really worry about that because ours has a pediatric key. Okay, so if you have an AED that has either the pad or a key type device, use it. Okay. And what they'll do is the pads. What they'll do is if it's one on the front, one on the back. Okay. If it's an older child, remember you got to keep them within an inch apart. Okay, because you don't want that arc to go across. So if you do have a smaller child, let's say 3, 4 years old, whatever else, you place them on there. If you put them on there, again, up here or down here, and if they're too close, you'll even put the one on the front, one on the back. Okay. But if you can get them across and where they're separated enough, go ahead and put them on the front.
How far they need to be separated?
About an inch apart. They need to be about an inch apart. They can't be touching. So I mean, if you have a small enough child and you've got more than an inch, put it on there. Video 2. All right, here we go. We got another video. This one is, Jay, if you wouldn't mind.
Where's it at?
No. Turn off my mic here in a minute. When I start the video, and then when it comes up on that one, if you'll just hit play for you guys. Again, guys, once this video is done, if you wouldn't mind just giving me a check mark, and then we'll move on from there. We'll move on and continue out. So, here comes the video. Alright. Laura Sullivan knew that person. She was from the same place that he's from. Alright. Chain of survival. Again, this is the 2005 early recognition of an emergency and activate the EMS, which will be us. Early bystander CPR, early the delivery of a shock, early advanced life support followed by post recirculation care delivered by healthcare providers. 2010 is these actions are turned the link in the chain of survival for adults. They include immediate recognition of the cardiac arrest and activated emergency response system, early CPR that emphasizes on chest compressions, rapid defibrillation if indicated, and effective advanced life support, and integrated post-cardiac arrest care. Okay, they may be touching on it here in a minute, and I'll just go over a little bit what some of the places are starting to do with that integrated post-cardiac arrest care. Okay, here it is. The additional of the fifth link in the chain is an integrated post-cardiac arrest care applies to both the lay and healthcare providers. There's not much that we're going to be able to do with this, but what they have done is and I think actually from what Captain Sousa said, Sarasota County's doing it, or Sarasota Hospital. When we go on there and we start CPR, or we go to an unresponsive cardiac arrest or whatever it is, if we can start the compressions early, defibrillate, advance to life care, ALS, get them to the hospital, we save them. What they are starting to do now is they are starting to lower the core temperature of the body with cold fluids. They're bringing the core temperature body down. And what they're doing is then they're leaving it down for a certain amount of time. I'm not exactly sure. They're leaving the core temperature of the body down to a certain temperature, and then what they're doing is just raising it back up. And Captain, I don't know if you know a little bit more about it than I do, if you want to touch on it.
Yeah, Sarasota County is currently doing this. Return of spontaneous circulation, what they found in the studies is that post-resuscitation, that in order to minimize tissue damage, they're lowering the core body to temperature down. Here's a slide that covers or it's covered in the video. So right away they want to start immediate cooling. Sarasota County injects boluses of cold solutions, cold saline solution through intravenously to bring the core body temperature down.
Obviously, that's something other that we wouldn't be doing. Not sure whether or not Nancy County is going to be doing it or not, but it's a possibility. Cricoid pressure. Again, anytime we go on a cardiac arrest, we think of cricoid pressure as when we're helping the medics to sit there and see visualize the vocal cords. Okay, but again, it can also be used to try to close down the esophagus to prevent some of the not aspirations, but putting air into the stomach. Okay, what they have done is the routine use of cricoid pressure in adult strut is not recommended anymore. Okay, so no longer if you ever did it, which the calls that I've run on some of the guys with some of you guys, different things like that, I've never seen it done. The only time I've ever really used it is when they're trying to intubate the patient through the visual cords. There are places that do that on a regular basis. Now what they're doing is let's get away from that completely. Only if you need to do it to visualize the cords. And other than that, no more cricoid pressure. So they took that out of there as well. It may impede the highlights. It may impede ventilation. Difficult to teach because there is a technique that you have to do it. You know, some people grab a hold of it. Some people use 2 fingers. So, and it may prevent advanced airway placement. Aspiration still can occur with they found. Regardless of expertise, rescuers cannot effectively apply the cricoid pressure. Okay, the team approach for healthcare providers. When multiple rescuers are present, they should rotate the compressor flow about every 2 minutes. The switch should be accomplished as quickly as possible, ideally less than 5 seconds, to minimize interruptions. Again, when we're on a call or whatever else, I know that we try to do that is when our 5 cycles is up, the other person will get ready, whether they were on the other side of the patient or whatever else. You get up, the other person will take over and be done. What they have done is the intent of the algorithm is to present the steps of BLS in a logical and concise manner that is easy for all types of rescuers to learn. Remember and perform. These actions have traditionally been presented as a sequence of distinct steps to help a single rescuer prioritize actions. However, many workplaces and most EMS and in-hospital recirculations involves teams of providers who perform several actions simultaneously on the record. Again, just like I said before with all of us, you know, if there's 3 of us on a truck, one of you is going to sit there and grab the AED, one of you is going to start bagging, and the other person is going to start chest compressions. The best thing to do is if you get in there, one of it, whoever has the kits or whatever it is, that person stick on that instead of putting it down, hey, you go over and do that. When you walk in, if we walk into a cardiac arrest situation, and let's say, for instance, Jay has the AED. All right, Jay, you know what? You apply the AED. And Billy, you happen to have the box, you're going to throw it down at the top of the patient, grab out the BVM, start at it, and then of course Eric, you're going to sit there and start compressions. Everybody does their whole thing. Start doing their jobs. The AED's on, no shock advised. Sit there and go, okay, let's wait 2 minutes or whatever else, 5 cycles. The AED's already on, so it's going to start counting from that point once it's turned on. Okay, it's going to let you know that, okay, 2 minutes are up. Switch your rotations. Everybody, maybe even let everybody switch. Okay, that way everybody gets a chance to change and doesn't get tired. Okay? Highlights. Tasks can be performed simultaneously, integrated with additional rescuers as they arrive. Designated team leader with multiple rescuers. Okay? A lot of times a captain or one of the lieutenants will take that role, or if one of the lieutenants or whatever else are there, they may designate one of the first class firefighters or someone else to step in and go, okay, you know what, you do whatever you need to do, especially once the EMS shows up or whatever else. A lot of times, like I know Captain Jasinski will kind of step back a little bit and maybe help out with gathering different things and medications or whatever else they need. I know on Chief Souders, I kind of stood back at the beginning and kind of helped get the IV set up, drugs and different things like that. Then once we got all that situated, we went over and then Rodney and I kind of switched back and forth on the questions. So I know each shift and each station, whatever else, has their own little way to do it that works for you. Keep it up. Just remember the team approach, all right? Always try to rotate as much as you can. Okay? Obviously, some they start with the lone rescuer and builds to more, whereas other video 3. Oh, video already. Oh, we got almost done. Okay, this last video is about a 20-minute video. It's an overview of everything that we went over. Again, pay attention to what. The updates or the things that they touch on, because some of the things that are in the video are some things that we didn't go over today. And just remember that we will be coming out next month with a test and a practical part of it. So.
And after the video, we're going to wrap everything up, answer any questions, and go over a couple other things.
All right, so here we go, guys.
You're on. Okay. You have sound on?
Yep.
And the
hold on. Video?
Yeah, the video. Oh, that's you can turn the video on.
There you go.
Okay, still waiting for Walker Sella, Score Sella. John Balder has a quick question, and his question reads, you can't read it, I'll read to you. It's been brought to your attention that Manatee County EMS is not adhering to these new changes. Will that affect what we do at all? John, turn on your mic and tell us what you heard and how you heard it, and we'll talk about that. Actually, turn on your video too, John. Turn on your video also.
The paramedic out here, Andrew Powers, had said that now is not going to change. I'll stay in the old way.
No, it shouldn't affect us at all. Because the only thing we're going to do differently now is
we're going to do it the way we're learning here today until we get here, but when that medic gets there, it says, what are you doing? 30 and 2.
But it is 30 and 2 now. It's still 30 and 2.
Okay, so what is the only difference? What's the difference between
Airway, breathing, circulation. Now circulation.
Compression. It's actually compressions or circulation, then it's airway, and then it's breathing, or ABB, and then it's breathing.
Yeah.
Okay, so it's not going to change. What it will do, and what they're saying, the AHA is saying, is that even in the circulation, they're saying that even healthcare providers, when they take that minute to open the airway, look, listen, and feel, that's 1 minute less of perfusion that someone whose heart's not beating is losing oxygenated blood being circulated. So what they're doing now for the layperson and also for the healthcare provider that arrives on scene is they're saying, forget opening the airway, forget look, listen, and feel, go right away to circulation compressions, which means check for a pulse for 10 seconds, and then if you can't find a pulse, begin compressions. Also in the circulation literature, they're saying that we take too much time checking for a pulse. And the fact is we're losing valuable time where we're not circulating blood. So the emphasis now is there's a residual amount of oxygenated blood in the body is what they're saying, and that the most important thing we can do is start the circulation via chest compressions. And there's residual O2, and that by doing the chest compressions first and then coming back and doing your ventilations after the first 30 compressions, you're going to be okay. Does that answer your question? Yeah. The other things, once they put an advanced airway in, everything else stays the same. The other emphasis is on the chest compressions. That it used to be at least 100 per minute. Now it's
it used to be up to.
It used to be at least 100. Now it's 100 per minute or more. Now, in other words, don't go less than 100.
Right.
Okay. Don't go less than 100. They're finding that we're going too slow. When we set it at least 100, that we're actually probably only getting 80 to 100 in per minute, where we should be getting 100 or more in. We use Dr. Solar. He's already reviewed the circulation. We're in the process of updating our protocol, which hasn't been done in 2 years. And Sarasota County's got a little dilemma going because they just published theirs in December, and what they did is they said within their protocol, which doesn't affect us, but within their protocol, they're going to come back with revisions to the new AHA guidelines. So anyway, it's a thing with each jurisdiction. Right now, this comes out every 5 years, and now you print all these protocols out, and if you just publish them, it's a big, intensive effort to go retrain lots of people right away. So we're small, easy for us to train everybody quickly, so we probably will be incorporating this by, I'm going to say, the end of February. Does that answer your question, John? Okay, all right, he said sure. Anybody else have any questions about the change at all? Okay. John, let's see, what else we just covered there?
I don't think there's nothing.
Okay, let me see. Okay. All this information can be found on Module 29 in web training. It's under the EMS training, Module 29. The videos are there. Direct link to circulation for AHA is there. You can read the literature behind why all these changes were made. So you can go to that website, to our website, and look at all the videos are there, and we'll be updating the protocol soon. Let me turn the lights on. I want to go over something real quick. All right. And this is going to be, move this out of the way a little bit. And move this way and see it. Hopefully you can see it. Getting far away. The lights. Yeah, the lights. Hard to see. Okay.
You can just write in that slot.
That's kind of hard to do. All right. A couple things on the video they mentioned with end-tidal CO2. And I'm just going to give you just a quick brief what it means and what it means to you guys. What they found is that the most effective way to measure whether you're performing good CPR, well, one of the most effective ways is if the patient has circulatory, or if they, well, color, you look at the color of the patient, but that's not really a good sign. What's a good sign is measuring end-tidal CO2. It's a good sign to measure whether you're doing good CPR or not. And there's two values on the Philips life pack that they have. One is waveform, capnography, and the other one is the percentage of CO2 in expired air. And how this works is on their device, and I don't know if you guys out in the island or out station 2 can see this, they went over it briefly in the video. And this is on their Philips. When you see a patient breathing normally, you're going to see waveforms like this, okay? In the air that we breathe right now, there is 0 CO2. So if I put a measuring tool for the capnography in the air, the reading is going to be flatline, because there's no CO2 in the air that we breathe, in ambient air. Okay, the only place there's CO2 is expired air. Normal expired air is 5%. It's measured in 5% oxygen. 5% CO2. You ingest 21% oxygen, or you breathe in 21% oxygen. The vital organs, including the heart and all the vital organs, the brain, they use that oxygen and then they expel it in a way called carbon dioxide. Okay, they blow that off, and it can be measured as either a percentage. And if you remember the end caps that we had, the colorimetric end caps that gave a color change from purple to gold, that was in a percentage. Or it can be measured in millimeters of mercury, which is digital, and then it's capnography, which is waveform. Okay? So, right here, on this right here is 0% CO2. Okay? And then as the waveform goes up, that's called exhalation phase. You're exhaling, it spikes quickly, and it flatlines, and then when the patient breathes in, takes a breath, he's taking in fresh oxygen, and then the waveform drops back down to the flat line to 0. Goes 0, the person then exhales, it goes up, then it goes flatline, he inhales fresh air, it drops back down. So that's waveform. That's how to read the waveform if they're breathing. Now if you're ventilating, what you're doing for the patient, it's on the Philips monitor. When you're set up for a cardiac arrest, you're sitting. Yes. So next time you're going out and checking with them, what you do is have them show you the Philips monitor and show them where the waveform is. Okay. Now the other thing is, as a matter of fact, in the journal, they're throwing away all of the journals, the American Heart Association said all those colorimetric devices, throw them out, they're useless. The only definitive way to say the tube, one of the ways to say the tube's in the right place is capnography, both digital and waveform, both together. Listening for the breath sounds, listening to the epigastrium, what other signs? Saturation. But anyway, so if you're doing now perfusion, think about it. CO2 measures a person's ability to perfuse. So someone perfusing normally, okay, their digital reading, their waveform, and this is like a scale, 0 to 60. The norm is between about 35 and 40 is the norm. So between 35 and 40 millimeters of mercury, Hg, is considered the normal thing. Okay? If you ever get on a patient with cardiac arrest, when you start doing compressions, they get them intubated. The only time you do this when they're intubated, but get them intubated, and then you start seeing this value in the digital reading. If you're doing good CPR, you should be seeing 20, 15 to 20 range. It's not greater than 20. If you're doing forced CPR, it's going to be below 15, and that's not going to sustain life. They're going to be dead. They may never change. You may start CPR, they may intubate the patient, they put the end-tidal CO2 on, they confirm it's in the right place. You start getting readings of CO2, 10, 12, 10, 12. One of two things. They're dead, or you're just not circulating the blood right, or there's some other mechanical problem that's going on where the blood is not getting circulated around. The optimum is to get it above 20. That's what the AHA says. And sustain it above there until you get return of spontaneous circulation. And that's the goal. And it's a way to measure whether you're doing good CPR or not. And I've seen codes where we'd start right away, we get them tube, we start the CPR, and we'd have a value of 10. And then once we get somebody pumping on the chest good, the value will rise up 18, 20, you change rescue, then it starts to drop a little bit, you change the rescuer, new guy gets on, gets a little more aggressive on the pumping of the chest, and the value then starts climbing back up again. I've seen that actually happen. Then I've seen what happens is after you've been in arrest for 10 minutes, I've seen this one arrest, what will happen is all the buildup within the blood, once they do return spontaneous circulation, you could get a situation where the end-tidal CO2 will spike like really high, like 40, because of all the buildup, because now they're heart pumping. So, are you going to? No, I'm not. Anyway, a question from Lieutenant Lee. Am I going to the building to hold the meeting? No, the meeting is coming up soon, and we'll be out of here. Any questions from Station 1? Somebody can turn their mic out at Station 1. Ask us any questions. Speak up. Don't be shy. They're good? Okay. Station 2. Any questions? We didn't get. Try that again. Okay. All right, that's it for today, and thank you very much, and we'll talk to you later.
All right.